Bonjour, good morning. My name is Chidi Oguamanam, a health law faculty here at University of Ottawa. On behalf of the director, Professor Colin Flood, and faculty colleagues at the Center for Health Law Policy and Ethics, and the University of Ottawa Interdisciplinary Center for Black Health, I am delighted to welcome Professor Ruqaiijah Yearby to University of Ottawa. Professor Yearby, our distinguished guest lecturer for today, is the Kara J. Trott Professor in Law and comes from Morris College of Law, Ohio State University. The Ohio State Health Law faculty ranks in the top 10 among public schools in the field, and it is reputed to produce influential field-defining research. Professor Yearby is one of the top-notch faculties of this great and impactful niche of Ohio State University, which is a treasure in the field of health law in the United States. Before joining Ohio State University, Professor Yearby, who is also the co-founder of Collaborative for Anti-Racism and also the Institute of Healing, Justice, and Equity, was a faculty at St. Louis University, Missouri. She specializes in racial disparities in healthcare, the political economy of healthcare, and social justice in medical research. Ruqaiijah is dedicated to a career where she deploys her expertise and constructive voice to improving the lives of vulnerable populations. Her interventions in the widening health access inequity during, and do we actually say after COVID-19, have been or have had some significant policy impact. One of my colleagues here in health law simply described Professor Yearby as a terrific US scholar who works on the issues of race in health care. That is quite simple, but it is profound because there are a multitude of issues in that space, an aspect of which, namely structural racism in the US healthcare system from historical perspective, is what Ruqaiijah is sharing with us today. I am confident there will be a lot in it for Canada. Professor Yearby, you have about 30, 40 or more minutes to speak. The audience is muted and invisible, but they are requested to submit questions using the Zoom question and answer feature, which you and I, the moderator, would select from the questions to answer. We aim to be done by 12:45 p.m. to allow folks to transition to other engagements. But as a housekeeping matter, there is an AI-generated automatic translation in French. The link is already shared in the chat for those who would want to receive the translation in French. Please now, friends, permit me then to invite Professor Yearby to commence her lecture. Thank you very much.
Thank you. Bonjour. I am going to move to my presentation. I wanted to thank you for allowing me this opportunity to speak today. I am going to focus on historical and modern day structural racism in the U.S. healthcare system, and my name is Ruqaiijah Yearby. So I am going to focus on three key aspects today on structural racism. I am going to talk about intersectionality and structural racism. I'm going to then go into specifics about how structural racism shows up in the U.S. healthcare system, and then provide a brief discussion of how we could potentially address this through the use of the health justice framework. So in terms of structural racism, there are many definitions of this term. This is the definition that I am using today. It is the way that practices, policies, and laws are used to structure systems, including the healthcare system, to advantage white individuals and disadvantage racial and ethnic minority individuals. It also includes the ways that organizations work together to create separate and independent barriers through the neutral denial of equal treatment that results from the normal operations of the institutions in a society. It does not require bad intent, and it goes beyond just individual actions. And so although I am talking about structural racism today because I was asked to focus on that particular area, I understand that there are multiple identities that are used to discriminate against people. And so you see race is just one of them. I am also going to talk about the intersection of race, class, and gender identity, particularly for women of color. But I did want to highlight that most of these issues are also impact other groups, including individuals who are poor within the United States. So, 4 key areas that I'm going to use as examples of structural racism in the U.S. healthcare system. The first being the misuse of race as a genetic factor. Then I'm going to turn to payment of healthcare providers, funding for healthcare, and access to healthcare. So under the misuse of race as a genetic factor, we can see that it leads to the belief that we are genetically different as races, even though the Genome Project has shown that we are more alike when you compare a white and a Black individual than actually 2 Black individuals. Furthermore, when we talk about race, we haven't even defined it clearly in terms of the U.S. healthcare system or the medical system. But how we have defined it, we usually do it in a way that minorities are inferior and that whites are superior in the standard. We see this in multiple areas in medicine, which is a part of the U.S. healthcare system. I'm going to focus on some of how this plays out in terms of medical guidelines and standards of care. These are just a few examples of articles that highlight genetic race. Some of them are from quite a while ago, 1947, and that is in the top left corner, whereas the one that is in the top right corner came out recently to talk about why there were racial disparities in COVID-19 infections, trying to blame it on some nasal gene expression and the differences between racial and ethnic groups. The problem with all of these studies is that, one, it reinforces the belief that racial and ethnic minorities are somehow inferior to whites, but it also does so without clearly defining what we mean by who is white and who is Black. And even though these are scientific studies, they were not able to scientifically distinguish the races because, again, the Genome Project doesn't support that. And so let me tell you how that specifically plays out. We see that particularly in the US with the discussion of sickle cell being a Black disease, and that is rooted in historical racism, where the first 2 people who are identified as having sickle cell in the US were of mixed race, and the physicians said that the reason they had sickle cell is because of their Black genealogy, which was linked to disease. We see that, however, sickle cell is not a Black disease. It is all over the world and really tended to link with malaria. One of the issues with it being labeled as a Black disease is that that means that there is usually little training regarding treatment, lack of money for research. Most of the patients are denied pain medicine, but it also means that we do not test for sickle cell outside of that particular race, which leaves many other people who are non-Black unable to receive treatment. We also see this in infant mortality rates within the US, and lots of discussion has been focused on the increased rates of infant mortality for racial and ethnic minorities. But the problem is that if we again begin to focus on this disparity, highlighting that in some ways that these races are inferior, then we miss the fact that one, it's not true across all races. As you see in this case, Asians have the best infant mortality rate. But two, we fail to understand that white people who can give birth also have a really poor infant mortality rate, and we do not address those issues. The last thing I want to highlight in terms of misusing race as a genetic factor, we see this also in breast cancer. And so one of the claims in breast cancer, particularly in the US, of why there is a difference between Black and white women is because there is some biological difference between them, and lots of money and time has been focused on this. However, when you dig deeper, what you see is that it actually is socioeconomic status, location, access to testing, all of those things which support the differences and actually disparities. And the last thing I do want to highlight on this slide is that when you actually track breast cancer mortality rates across different cities, you see that for the most part, they were the same until there were changes in testing, and many Black women were not able to get access to breast cancer testing in a timely fashion. And so you see increased rates of mortality in Black women. Now, I want to focus on another area, particularly payment of healthcare providers. And so I'm going to highlight one group, home healthcare workers. And these are individuals who aid with activities of daily living for the disabled, for the elderly in their homes. They perform some clinical tasks, such as taking blood pressure readings and administering medication. Almost 2/3 of home healthcare workers are racial and ethnic minority women. A majority of them are living in poverty compared to other workers who provide care in nursing homes and in the average population. This is important because one of the main funders for home healthcare workers is the federal government and state governments. And so the link that I want to make here, again, going back to structural racism, two key components, right? It's the laws, it's the practices and the policies around payments. And it's also the ways that institutions work together to not pay these workers who are providing healthcare services and not able to actually access healthcare themselves, which I'll talk about a little bit more later. Some of these issues have been associated with poor health outcomes for these workers. Home healthcare workers not only have the highest rates of workplace injuries, but they also have worse general physical and mental health compared to other low-wage workers. And in fact, home healthcare workers have higher rates of workplace injuries than construction workers, which we think of as a very hard and dangerous job. Home healthcare workers tend to have higher rates of musculoskeletal symptoms, back injuries, and back pain than workers providing care in nursing homes. And this is in part because usually they're doing the work in the homes by themselves, whereas workers in the nursing home have help. They also have instruments and medical devices that can help lift people. That prevents them from getting hurt. 1 out of 4 home healthcare workers rated their general health as fair or poor. 1 in 7 report poor physical health, and 1 in 5 reported poor mental health, which was significantly higher than healthcare aides and health support workers not working at the home. One of the reasons for this trend of having fair or poor health, it was linked to low pay. It was also linked to higher rates of injuries. And again, this goes back to practices, policies, and laws that underpay these particular workers and do not provide them with the health and safety and supports that they need. Why is this an example of potentially of structural racism? Because one, the population that disproportionately does this is racial and ethnic minorities, and the laws do not require them to be covered in terms of support, in terms of wages. And so I will talk about that a little bit more later. I want to turn now to a discussion of funding for healthcare. So historically, in the U.S., the government has provided funding for a lot of the construction of hospitals and other institutions in which people get their care. Now, a lot of this funding comes from the Social Security Act, as well as other acts that tended to fund the construction and placement of hospitals in a way that primarily funded hospitals and institutions that were providing care to white individuals versus people of color. Before the Hill-Burton Act was passed, a majority of the funding that went to fund hospitals and these institutions was limited to private institutions. Those private institutions predominantly served white individuals. The majority of racial and ethnic minorities received their care in public institutions, which were not being funded by the federal government, the state government, and really did not receive funding until the enactment of the Hill-Burton Act. With the Hill-Burton Act, the government, the federal government in the U.S. provided funds for public institutions, for the construction of public institutions, which seemingly then would address the disparities in funding for care that was provided to racial and ethnic minorities. But it did not, because it included an exception that allowed for states to apply for funding to create separate and unequal facilities and to keep racial and ethnic minorities in these facilities that were underfunded. Some of the states that did that were Alabama, Florida, Georgia, Kentucky, Louisiana, Maryland, Mississippi, Missouri, North Carolina, Oklahoma, South Carolina, Tennessee, Virginia, and West Virginia. And so what we see under this law, policy, and practice is that the government would provide funding for the construction of public hospitals, but that equal funding would not go to institutions that were serving racial and ethnic minorities, even though these individuals were paying the same amount of taxes that was being used to construct these hospitals. Fast forwarding after that practice to the current day practice of funding for healthcare, we see lots of the same issues when it comes to structural racism. I'm going to focus particularly on Medicaid. And so let me tell you a little bit about what Medicaid is. Medicaid is a federal and state-funded program that provides healthcare coverage, health insurance coverage for individuals who are poor. After the passage of the Affordable Care Act, we see that states could receive additional money from the federal government to expand Medicaid to cover more individuals. This slide shows across the country who has expanded Medicaid and who has not expanded Medicaid. This is important because a lot of the working poor do not have access to health insurance. And so the expansion of Medicaid actually provided coverage, health insurance coverage for those individuals. It would cover and provide health insurance coverage for some of the home healthcare workers who are predominantly women of color. Research shows that state Medicaid expansions decisions are not affected by the level of support by racial and ethnic minority individuals. Instead, Medicaid expansion is positively related to white individual support of expansion. And what the research has shown is that if Medicaid expansion is tied to any benefit for racial and ethnic minorities, then the states will not expand it. So again, this is an example of how structural racism plays out, particularly in the funding for healthcare and Medicaid expansion, because if there's any belief that the expansion is going to help racial and ethnic minorities, then it tends not to pass. Furthermore, this slide just shows an example of the states that have not expanded Medicaid that would benefit how the racial and ethnic minorities in those individual states would benefit from the expansion of Medicaid. Furthermore, I wanted to highlight how this disproportionately harms racial and ethnic minorities is that in the states without Medicaid expansion, there is a high gap in medical debt for everybody in the community, but disproportionately for racial and ethnic minority individuals. And finally, I wanted to highlight some of the key components of this. So not only does this impact disproportionately racial and ethnic minorities, the poor, women, but I wanted to bring us back to how does this play out in the healthcare system. And from this slide, you can see that many workers in the healthcare system who were labeled as essential workers during COVID-19 fall in the coverage gap. So what does this mean? This means that they do not have access to health care because, one, we haven't expanded Medicaid, but also because here, unfortunately, in the United States, access to health care is limited based on your ability to pay, traditionally through health insurance, which is usually obtained through your job. And so how is this structural racism in healthcare? Because even those who are working within healthcare in the United States are left without access to healthcare, without access to health insurance. And when we break down who is working within healthcare, who usually lacks access to this health insurance, it is disproportionately racial and ethnic minorities, including those working as home healthcare workers and other areas. Now let me turn to access to healthcare. One of the things that I wanted to highlight in access to healthcare, which is different from your system, is that a majority of people's ability to access healthcare services, even preventative services, is really tied to their ability to pay. We see here the disparities in healthcare coverage of the non-elderly population by race and ethnicity. And what you will see, not only just a difference in who is uninsured, but also a difference in who is covered by Medicaid. And so you see that 74% of white individuals have private insurance, and that is primarily due to health insurance through their employers. You see the same high percentage of private health insurance from Asian individuals. You see less so from Black, Hispanic, and Asian, Pacific Islander, Alaska Native, a much lower percentage. And then you see with whites, 8% are uninsured, Asian individuals, 7% are uninsured, but much higher rates of being uninsured for racial and ethnic minorities. How does this play out? it plays out in disparities in access to healthcare. And so what this slide does, and this is from the 2017 National Healthcare Quality and Disparities Report, where we see that there are differences in access to healthcare. And this pulls together a number of different areas of access to healthcare, including being able to be seen by a healthcare provider. And what you see is that it compares poor versus high income, right? That a majority of poor income, low income have worse access compared to those who have high income. The same thing for Black versus white. We see in other groups. Now, some other things I want to highlight that were in the study too is that a 2017 study using records from 2006 to 2013 found that Black individuals and Latino individuals suffering from neurological ailments like stroke, Parkinson's disease, and Alzheimer's dementia are likely to receive significantly different and less adequate care than white individuals. This discrepancy in treatment, which impacts diagnosis, specialist care, treatment, and recovery, exists even when the patients of different races or ethnicities have similar incomes, insurance status, and level of education. The study, which involved about 280,000 patients, found that Latino patients were 40% less likely to see a neurologist for their condition than whites, and Black patients were nearly 30% less likely to see an outpatient neurologist than whites with similar resources and education. Now, I want to stop here and say, just remember how I started this discussion about the misuse of race in medicine. What we tend to do with these disparities in access, disparities in health outcomes, is try to look for a genetic difference. And what I am saying here is that it is social, right? It is about discrimination and racism that impacts people's ability to get the care that they need. And so instead of us trying to look for a genetic difference, what we really need to do is focus on the laws, policies, and practice that have structured the healthcare system and access to healthcare in a way that people who are Black, Latino, Native American do not receive the same services as white individuals, which is problematic. The last thing I want to highlight about access to healthcare, particularly on this slide, is that African Americans were also considerably more likely to be cared for in emergency departments and to have longer hospital stays and higher inpatient expenditures than their white counterparts, again, because of these laws, policies, and practices. Now, as I mentioned in my initial discussion about structural racism, I also want to highlight how this has a harmful impact on another group, women. And so one of the things that the Affordable Care Act, the ACA, did for the United States was that it was supposed to make some visits, particularly for preventative services, free, right? So trying to eliminate the barrier of access to healthcare based on the ability to pay. But what we see is that institutions still are charging women for these services, which means oftentimes that women forego these services. 1 in 5 women reported paying out of pocket for a recent pap smear, 13% for a mammogram, and 7% for colon cancer screening, which is supposedly prohibited by the law. 1 in 5 women have postponed preventative care, skipped a recommended treatment or test, or made medication trade-offs, such as not filling a prescription or cutting dosages. 49% of uninsured women went without or delayed care because of cost, while 47% postponed preventative service and 42% skipped a recommended medical test or treatment. And this is based on a Kaiser Family Foundation report. Why is this so important? Because if people can't access the healthcare services that they need, that tends to be associated with some form of health disparities, meaning that they have higher rates of untreated conditions that then are only addressed later on when it is too late, perhaps in terms of cancer, or when the problem costs a lot more money to address. And so why do we see these things, even though I want to highlight that there are some laws on the books that are supposed to prevent that? And so in my prior discussion about funding for healthcare, I mentioned Medicaid and the Hill-Burton Act. In access to healthcare, we have Title VI of the Civil Rights Act of 1964, which is supposed to prohibit racism, sexism in the provision of actual healthcare services. And in fact, Title VI of the Civil Rights Act of 1964 only focused on race. It wasn't until the enactment of the ACA under President Obama where sex discrimination was actually prohibited in healthcare services. So what do I want to highlight in this particular aspect? This law in and of itself seemingly provides protection against issues of structural racism, but it does not, because the federal agency that is responsible for enforcing this law decided that this law against racial discrimination, racism, only applied to institutions. So they didn't apply it to physicians, meaning that physicians were legally allowed to racially discriminate against individuals. This law, along with Medicaid and Medicare, was used to racially integrate hospitals as well as schools, but today I'm just focusing on hospitals, yet we have not seen it actually lead to equal healthcare services for racial and ethnic minorities, let alone equitable access to healthcare resources. And I'm going to use just a couple of examples from COVID-19 just to talk about how we continue to see race and discrimination play itself out in access to healthcare. And so the picture is showing a Brooklyn teacher who died from COVID after she was twice denied a COVID test. There are many instances throughout the COVID pandemic where individuals who were racial and ethnic minorities were denied access to testing, to treatment for COVID-19. This is just one example. There was another example of a nurse in Detroit who actually went to the hospital she had worked at for 30 years and was denied access to COVID testing, and thus was denied access to actual treatment. What is interesting about this, though, is that you don't tend to see lawsuits brought by racial and ethnic minorities who do not receive care. What you tend to see is more when people are trying to rectify these issues in the healthcare system, that then white individuals are the people who are suing, preventing racial and ethnic minorities from getting equal and equitable access to healthcare. And so what do I mean? The list at the bottom talks about a Cornell law professor sues New York over racial discrimination and treating COVID-19. What New York did was try to adopt an index to provide equitable access to COVID treatment and to vaccines for those who were most impacted by COVID-19, which traditionally was poor individuals and racial and ethnic minorities. But their work to actually focus on the people who were most harmed was challenged by a lawsuit and had a chilling effect, not just in New York, but in other areas like Minnesota and Utah, who were trying to adopt protocols that would have specifically focused on the people who were most harmed, and they wound up deciding not to do that because of the fear of lawsuits by white individuals. We see this playing also in Michigan, and what I want to highlight here is the picture at the bottom that talked about white Michigan residents get COVID vaccines at twice the rate of African Americans. So a research study came out actually saying that white Michigan residents were getting the COVID vaccine at twice the rate. That was connected with the fact that a majority of the people dying infected from COVID-19 were racial and ethnic minorities, particularly Black individuals. After this study came out, the Michigan GOP then set forth a policy that said that race cannot be used, race nor socioeconomic status could be used to provide vaccines to people. So what does that mean? We have research that says that white individuals are getting the vaccine at twice the rate of other individuals, particularly racial ethnic minorities, and that the poor don't have access to these vaccines. And so instead of actually addressing that, what the legislatures wanted to do was to enact a law that ensured that that would continue, right? Not only ensure that white individuals would continue to get more vaccines, but that poor individuals would not be able to get more vaccines. And so this shows how that law could be used as a way to further advantage white individuals who were already getting more, but also not being as harmed as much as other individuals. And in this instance, they looked at race and socioeconomic status. I do want to highlight just one more example of this, particularly in the rollout of other COVID vaccines in Dallas and in Missouri. What we saw in Dallas was that Dallas County's rollout plans for the vaccine included an inoculation hub in a predominantly Black and Latino neighborhoods. But when the sign up website went live, it was circulated through white, wealthier districts in North Dallas. And so those were the individuals who were actually able to get the vaccine. When county officials tried to hold doses for racial and ethnic minorities residing in the neighborhoods where the actual vaccine distribution was happening, they were threatened by the state to withhold county supplies, and thus then had to give out the supplies to whoever would register for them on the website. And again, this is an example of how structural racism and classism plays out. Right, those who have more access to websites, power, and materials are able to get doses that were supposed to go to people who were poor and racial ethnic minorities and people who were disproportionately harmed by COVID-19, many of them healthcare workers. We see this play out as well in Missouri, where the Missouri governor would not send out doses to Kansas City or St. Louis, which were predominantly low income in areas that had a lot of racial and ethnic minorities. However, he did send out doses, about 2,000 doses, to a town that had only 69 people, and many of those doses were wasted while the other communities were waiting for access to doses. So in summary, I just want to highlight how the structural racism played out in the U.S. healthcare system. As I mentioned, the misuse of race as a genetic factor to explain some of these inequities in health and health outcomes, when we know and research has shown that it really is about how we structure the system to disproportionately advantage white, wealthy, individuals and to advantage those individuals and disadvantage racial and ethnic minorities, the poor, and women. We see the same thing in the funding for healthcare and access to healthcare, whether it be insurance or actually access to treatment or vaccines. This disproportionately harms racial and ethnic minority individuals, women, and those who are poor. And the outcomes we see then are racism, inequities, and access to healthcare and health status, which also includes poor mental health. And so what are the ways that we can begin to think about addressing these issues? One, I really highlight, based on the work that I have done with professors Emily Benfer, Seema Mohapatra, and Lindsay Wiley, is the health justice framework. So really moving us to think about some key things that we can do to change the structure of the U.S. healthcare system. One of those is to focus on adopting a truth and reconciliation process that acknowledges the existence of racism and the other isms, right? Sexism, classism, ageism, and ableism, and provide a mechanism to overcome that trauma that impacted communities, particularly racial and ethnic minority communities and other communities impacted by discrimination, must be centerfold in driving or leading the change. And that includes the creation, implementation, and value of any right to health and healthcare. A right to health and healthcare also must be accompanied by financial supports and accommodations to try to address the historical and modern day structural racism and the harm from these issues. That is not just based on the policies that we saw before during the Jim Crow era of segregation, but that they continue intergenerational harm, and that harm and those practices continue today. So how does this play out, particularly in terms of the U.S. healthcare system? One is the requirement to be honest about racism in the U.S. healthcare system. And so we've already seen some movement in the US to talk about how racism is a part of our clinical algorithms. And so what do I mean by that? The fact that we use race to determine who is going to get tested for sickle cell, the fact that race plays a part in and kidney function, right? So right now, as a Black individual, you have to have a worse kidney function to get on a kidney transplant than a white individual. We also see it in the fact that many of the medical devices have not been tested on racial and ethnic minorities. And so we see this on pulse oximeters that are supposed to be used, placed on your fingers to read oxygen levels, but they do not pick up correct oxygen levels on darker skin, right? So being honest about how racism plays out and whites being the standard, but also in the ways that we think about poor health and trying to link it to genetics and trying to link it to an inferior genetic makeup of racial and ethnic minorities. We need to be honest about that, but we also need to be honest about the fact and the role the government has played in continuing to harm racial and ethnic minorities and healthcare providers by paying them less than a living wage. This truth and reconciliation process must acknowledge the existence of racism and offer individuals from less privileged groups a mechanism to recover from the trauma of experiencing this racism. We also need to talk about racial and ethnic minority workers and patients need to drive and lead the change to address structural racism. So they should be the ones working with the government to decide how to change these policies, how to change the policies of how to fund healthcare institutions so that they are accessible and equal for racial and ethnic minorities. We also need to provide money and access to healthcare for individuals harmed by structural racism. And so what does that look like? Ensuring that those individuals have access to good, high quality health insurance, but that even having that health insurance is not enough if they're going to be turned away from the care that they actually need. So with that, I want to end with just providing a slide here of a couple of articles that go into deeper discussion of some of these issues that I have highlighted. The one at the bottom, I do want to highlight that I co-authored, talking about systemic racism in nursing homes, really highlights how racism throughout the healthcare system impacts not only the workers and the patients. And then finally on this slide, we also, in a co-authored article that I did, focused on critical crisis standards of care, which were used to determine who could get access to COVID-19 treatment. And so with that, I want to stop sharing, and then I look forward to any questions that you have for me.
Thank you very much. This is quite a lot to pack in, and you did it beautifully well. So we are inviting questions from the audience through the Q&A feature of the Zoom software that we're using. So let me say misuse of race, payment of healthcare providers, funding of healthcare, access to health. There's a lot trajectory for inequality and racism in healthcare United States. So we invite interventions from our audience. To kick off that conversation, I wanted to ask you, in terms of those states that did not expand the opportunities afforded by Affordable Healthcare Act, did you sense some correspondence with political leanings, that is to say, the divisions between Republicans and Democrats that actually characterize the politics of the United States? Is there anyhow that is manifest in relation to how the states have responded to expanding or not expanding the opportunities in the Affordable Healthcare Act?
In some cases, but it's not always definitive. What is more definitive is how the expansion is connected to racial and ethnic groups and not necessarily just the political leanings. And why I say that is that one of the states that initially expanded Medicaid was Ohio. And Ohio is thought of and has been led by Republican governors for a very long time. The Republican governor who was in office at that time chose to expand Medicaid to cover individuals. And so, although definitely the U.S. is becoming more polarized around Democrats and Republicans, that is not necessarily always the case in their decisions to expand Medicaid, particularly if they believe that it is going to help their constituents, particularly their white constituents. And so what I will say, though, a little bit is that a majority of the people who did not expand Medicaid tended to be in the South and tended to be in places where a majority of their individuals were poor and would greatly benefit from Medicaid expansion. Their choosing not to do that, however, was traditionally linked to race. The last thing I will say is that one of the things that Missouri was one of the places that just expanded Medicaid, and they were able to do so through a vote by their citizens because they highlighted how it would benefit everybody within the state. And even then, it took several years and several lawsuits for the government to actually adopt and expand Medicaid. And when they were trying to fight against it, it wasn't a Republican issue. It really was them trying to frame it in a Black versus white issue.
Wonderful. This is very helpful. We got some questions popping up. I'll try and pose them for you, maybe two at a time, and see if you could coordinate. And if not, I could take them separately as well. So this one is coming from Schwab Bakombo. And he says, thank you for a great presentation, but he has this question. Has Obamacare improved the outcome for African Americans in terms of access to care since its implementation? If you want to take that, I will be okay with that. And then I'll pose the second question.
Yes, and so it depends on what you look at in terms of factors when you say outcome for Black individuals. And so why do I say that? Part of the ACA Obamacare was to expand Medicaid to provide coverage to those who were poor, including those who were working to gain access to health insurance. So from that realm, you could say it didn't necessarily improve it in the places that didn't expand Medicaid, because our Supreme Court decided that that was not a requirement that all states had to do. And so from that perspective, no, in the sense that it didn't improve access to healthcare for those individuals in states that did not expand Medicaid. But on other areas, if you just look broadly, yes, it did increase access to healthcare in some realms. Why? Because it didn't necessarily expand employer health insurance, but it provided other ways for people to gain access to health insurance through health insurance markets. And so I would say to some extent it did, but there are still plenty of gaps out there. So hopefully that answers the question.
Thank you very much. This next question comes from Ivy, and it's really the one that resonates with us here in Canada. And the question being asked is maybe by way of comment, but then there's a question at the end of it. It says, I find it ironic at best, but unacceptable more to the point that so many racialized health workers do not have access to the care that they deliver each and every day. I suspect there is a shortage of healthcare workers in the United States, like we're experiencing here in Canada and elsewhere. Is there any discussion of covering these workers in terms of sick leave and access to healthcare to ensure fair retention? And let me add, this is a very important question, to the extent that in Canada here, we're dealing with that problem, and it's all about platitudes at the height of crisis. You see politicians praising them, trying to completely celebrate them by way of words and not by way of action. So there is a scarcity of healthcare workers, particularly those who deliver home care and those who work in institutions and homes. And so the question is really very important. Any discussion of covering these workers in terms of sick leave and access to healthcare to ensure their retention, that is very important for us here in Canada as well.
Yeah, so let me take some time to try to address the multiple points in that question. And so one, yes, it is quite ironic that healthcare workers are not covered, particularly now I focused on home healthcare workers. There's a broader group and category of direct care workers who provide care in nursing homes as well as in the homes of individuals. Those direct care workers are predominantly women, older women, and women of color. They live in poverty, don't have access to health insurance, and often tend to be covered under Medicaid if they can get it, sometimes under Medicare because they qualify based on age. I do want to also highlight some other healthcare workers that traditionally do not have health insurance, and those are people working in hospitals who provide food services, who clean the rooms, just so many low-wage healthcare workers who are not getting paid enough, don't have paid sick leave, and do not have health insurance. During COVID, there was a movement by some individuals to think about expanding coverage for them in terms of health insurance and paid sick leave. I will say, though, that one of the major bills in major laws in the U.S. to provide some paid sick leave and other economic benefits to workers in the U.S. specifically left out home healthcare workers because the industry basically band together and said, if you provide them with paid sick leave, they will not show up for their jobs. And so, yes, that is, again, a tension where you would think they would recognize that these people are on the front line. They don't necessarily have access to masks. They're working in direct contact with people. You want to provide things that not only protect them, but the people that they're serving. And when they were pushed to do it, they decided not to. There are movements to begin to try to provide health insurance and paid sick leave to these individuals, but they tend to be very state-based and very sort of patchwork. So there are movements to do that in Washington, the state of Washington. You see definitely a move to try to provide and negotiate higher wages for these individuals, health insurance, paid sick leave. You also see that some states that did get funding from the U.S. federal government using that COVID funding to provide extra money for these workers. I definitely think that is one of the reasons you see shortages in these healthcare workers, and that goes long term, meaning that these shortages began, I want to say, at least most prominently in the 1980s and have continued because in part we have not passed laws to give them health insurance or paid sick leave. And so I don't think that here in the US we have that much of an answer other than, like I said, state by state sort of patchwork of things. And in the US, what we tend to do then is change our immigration laws so that people can immigrate to the US to provide those services. But usually if they do that, they still don't have access to health insurance, paid sick leave, or other things that they would need to continue to address this issue. So hopefully that answers that. I am going to answer another question in the chat, and I will go ahead and read it out. It says, I appreciate this is a bit off topic, but prior to this presentation, I was unfamiliar with the work of the Institute for Healing Justice and Equity, IHJE. Are you able to share some of the Institute's philosophical approach behind its work, including the concept of healing justice? This is a thought-provoking concept that I have not heard before in the Canadian context. Thank you. Yes, I definitely can. And so I would mention that a lot of the work that I have been doing over the last 5 years is really connected to the Institute and our approach to try to address and eliminate systemic oppression that disproportionately harms individuals. And we try to do that not only through looking at the ways that laws and policies set up systems in a way that disproportionately harms these groups, but we also want to include healing justice in that concept. And so what does that mean? It goes back to what I was talking about, truth and reconciliation, but we add healing to that, right? It's this belief that in order for us to undo the harm of oppression, and when I say oppression, I mean racism, sexism, ableism, ageism, homophobia, that in order to address those things, we first have to be honest about the ways that we as the government institutions have perpetuated that harm. We also have to provide opportunities for those who have suffered from that harm to heal from it. One of the ways ways that you do that is providing mental health services, providing opportunities to have people be heard about their experiences, acknowledging that their experiences are correct, and providing some financial and other supports to allow them to be able to get past this trauma. What we tend to have in the U.S., and perhaps you've heard about this, is we tend to talk about trauma-informed care, that we understand that trauma impacts people, but we never go to the next step of talking about the ways that we are going to work to heal and help people heal from this actual trauma. And so those are the things that we are doing in the Institute. And one of the things that I will do is try to also put our website in the chat, which I am hopeful then you could access, so that you can see more of the work that we have done. One of the things that, let me put it in for everybody. One of the things that I have mentioned is that some of the reports we have done about lack of access to health insurance or other measures, you can find on our website. So with that, I will turn it back over to see if there are any additional questions that people have.
Thank you very much. I want to pose one other question on my own, using my liberty as moderator. You said something about white people being proactive to challenge laws that try to adopt protocols that will accommodate racial minorities. That is very profound. And I was wondering if there has been some counteracting response by way of amicus in courts and some civil liberty organizations trying to step into this very space, because it looks like an aggression and bullying that standing in a place of privilege, trying to suppress policies and laws that can accommodate the less privileged. So I wondered how that dynamic is playing up in the civil society, particularly among African Americans and Hispanics and other racialized minorities in the United States.
It is hard to be able to address it. And so one of the slide that I showed with the Cornell law professor suing New York, that was just one instance in court, but not everything winds up in court. And so what you will see is that groups that are purporting to support equality, really calling hospitals, pushing states behind the scenes to not adopt these things. And what tends to happen is that the hospital changes its policies, or the states, like I said, Minnesota and Utah withdrew their policies to actually equitably distribute these things. So yes, it does have a chilling effect on trying to get to equal, let alone trying to get to equitable. So equal would be that everybody is treated the same, and equitable means that we would actually give the resources to the people who need it the most. And so it has had a chilling effect on that. The last thing I would say is, because our judiciary tends to want to believe that how you address past and current practices of discrimination is by treating, ensuring that white individuals are not harmed, that often if you're trying to challenge these policies as a racial and ethnic minority, you cannot. And so even trying to challenge the fact that vaccines that were supposed to be used for racial and ethnic minorities in poor neighborhoods, a court would probably throw that out, because they would say, well, you know, that could possibly harm white individuals. And so we are going to allow them to be able to take doses that were originally set for people who we could see were having higher rates of COVID-19. Unfortunately, it is the legal structure right now is not is not set up to be able to make sure that everybody gets what they need. But what you do see is some states that are really committed to ensuring that poor people, racial and ethnic minorities, and other groups get what they need. They just move on and continue to fight the lawsuits. And push back against calls from the groups who are trying to pressure them to continue to advantage white individuals.
Thank you. There's a question for you on the chat. I'm sure you can access it. There are two of them from Sophie, I think it is.
Great. I am going to read out the questions. You said Title VI has been interpreted to only apply to institutions, not to individuals. Is there any mechanism whereby institutions might be made responsible through vicarious liability or some other mechanism for the actions of their healthcare worker employees? I'm going to stop with that, and then I'll come back to the second one. No, there has not necessarily been, and I'm going to speak to why. And so Title VI initially was quite strong. Because what it did and what the government did was connect it to Medicare and Medicaid funding and use it to push most hospitals to racially integrate. After that main push, the government kind of decided that Title VI, complying with Title VI, would be really based off of what people said and not what you saw. Furthermore, they did not push nursing homes and other institutions to racially integrate. And so what you tend to see still is racial segregation in most institutions, and U.S. Department of Health and Human Services not really enforcing Title VI when it comes to racism discrimination. And so even that, in terms of institutions not discriminating against people they're trying to treat, has not been enforced as it should be. And so we haven't gotten to the point of then holding their healthcare worker employees responsible. You tend to see these problems a lot with the placement of healthcare institutions. And so in the U.S., we have many healthcare institutions that have consolidated. And usually when they consolidate, they'll have some hospitals and healthcare institutions in poor neighborhoods and in racially segregated nursing neighborhoods that have predominantly Black and Latino individuals. And what they will do once they consolidate is close those hospitals, leaving no healthcare access to those individuals. There have been a few lawsuits against hospitals for doing that in healthcare systems, but courts have thrown those out, saying that they have that individuals, private individuals, have no rights to sue. Now, one of the things I do want to highlight in the U.S., Native Americans are their own tribes, and so much of my work doesn't go to them because they have their own rights, which is negotiated differently with the federal government, but there are still lots of issues there. Let me get to the second question. You spoke about institutions charging for services when there's a problem, when it is prohibited by law. Is there any accountability for these kinds of illegal actions? No, because part of the issue with the U.S. healthcare system, but with the U.S. Rights-based system, the U.S. Constitution, is that most of the burden is on the individual who is harmed to try to rectify the harm. And so it is up to usually the individual who is in charge for those services to bring a lawsuit to begin to challenge it. And unfortunately, many of those individuals do not have the time or the money to do it. What you tend to see happen is that you'll have a big news story that is either published in the Washington Post, the New York Times, the National Public Radio, NPR, highlighting these issues, and then the healthcare system beginning to change it and refund things. But it is rare that on the whole, the federal government or the state government will take take on this role and sue the hospitals or institutions for overcharging people. So hopefully that answers your question.
Thank you very much. This will be exactly the most inconvenient place to tidy up, and we want to thank you so very much for spending the time and sharing with us your expertise, and those are very relevant for us here in Canada in so many ways. Misuse of race, payment of healthcare workers, funding of healthcare, access to healthcare, those are historical and contemporary trajectories for healthcare inequity in the United States. And we have enjoyed your pathway to having a health justice framework and in truth and reconciliation, which is actually something that strikes a very important chord in Canada. So Ruqaiijah, on behalf of the director, Colin Flood, and faculty and colleagues at the Center for Health Law Policy and Ethics and the University of Ottawa Interdisciplinary Center for Black Health, I am very happy to say thank you very much for spending your time with us. And we look forward to working with you down the road because of the incredible research you are doing and its relevance for us here as a faculty and for Canada as a country. Thank you very much.
Thank you. Thank you for having me. I so enjoyed this talk, and hopefully it was helpful to not only you, but the participants. And feel free to email me if you have any questions.
And I thank our audience. They've been very active on scene, but very, very active. Thank you.